Good evening to all. This is Dr. Suresh hosting this online session. Welcome to the day 2 of online workshop on A2Z of cancer genomics. So we have 2 sessions today. To introduce the first session speaker, I invite Dr. Kripa Shankar, medical oncologist from Coimbatore.
Very good evening to everyone. And I'm just going to set the ball rolling by introducing our first speaker, who is none other than Dr. Aparna Dhar. She needs no introduction in the field of molecular oncology. And she is a trained medical geneticist with over more than 18 plus years of experience. And she's basically been working in the academia and in the industry as in aspects of genetic counseling, precision medicine, and also in consumer genomics and molecular diagnostics, which are her passion. And is trained at Mayo Clinics and the University of Glasgow. Her unique skill sets involve, she's been involved in a lot of clinical research, she's got a lot of publications to her name, and she's into a lot of genetic counseling and personalized genomic testing as well. She's worked and led projects at prestigious institutions like Mayo, MIT, Harvard, National Health, NHS, Scotland, and the Harvard Medical Foundation. And as far as her academic credentials are concerned, she's done her MMSc in medical genetics, MS in genetic counseling, MSc in molecular oncology, MPhil in medical genetics, PhD in genetics and genomics, medical fellowship in medical genetics, and also in clinical molecular genetics. And she's also board certified, clinical certified cancer genomics and precision oncologist. So she's got a, I can go on. Time definitely is going to be a constraint. I can go on about her achievements and what she's done in the field of genomics. And her present affiliation, she's director of the Hereditary Precision Oncology and Genetic Counseling, Molecular Oncology and Cancer Genetics Department, Max Institute of Healthcare. And she's also had a lot of achievements to her name, chief of them being she was awarded 2025 Genetic Counselor of the Year. And she's also at the Precision Medicine India Awards in 2025. And she's also won the best at BW Healthcare World Under 40 Award, which she won in 2024. And in 2023, she's won the Dynamic Health Leadership Award as well, and various other awards to her publication. She's presented at ASCO, ESMO Asia, and ASCO breakthrough sessions as well. She's won the best poster presentation at 2024 at ASCO. So without any further ado, I'll hand it over to Dr. Aparna. Over to you, ma'am. Take us.
Good evening, everybody, and thank you so much for that. It's kind of awkward hearing all of that, but thank you so much. And thank you so much for having me here today. Can I share my slides? Yeah, if you can just stop sharing, then I'll go ahead and share my slides. All right. So I've been given a task, quite the task actually, to talk about the role of the clinical role and utility of using, what are these called? Liquid biopsies in our clinical practice. And what I'm going to try and do is make it a little bit simple with respect to how we apply it to our clinical practice. I've been told it's a mixed crowd of pathologists, medical oncologists, and a couple of geneticists. So I'm going to try and keep it with respect to the clinical aspect, but I'm always happy having conversations after the talk and hearing everyone's point of view. So let's get started. When I think of liquid biopsy, what do I think of? Anything that's in a liquid form. So it could be a urine sample, it could be a blood sample, it could be cerebrospinal fluid, it could be anything. Now, in clinical practice as of today, there's some great work happening of using urine. There's great work happening of using CSF, but I'm going to be sticking to blood today to uncomplicate this situation. So when I take a blood sample of a patient, what are the components I expect to see in it? I'm obviously going to see RPCs. I'm going to see genomic DNA, genetic DNA, the DNA of that particular individual. I'm going to see discarded in our cancer patients, discarded cells, cancer cells, intact cancer cells, which is what we call circulating tumor cells. What does circulating tumor cells mean? Circulating tumor cells mean that from the cancer site, from the tumor site, the cancer cell discards an intact cell into the bloodstream, and that's what gets picked up over here. we also see something called circulating tumor DNA. Circulating tumor DNA is essentially from the cancer cell. When a cancer cell lyses, it releases the tumor DNA, the somatic DNA that gets released into the blood. So that is something that you're isolating. Then we have this new concept that in addition to this, we also see something that are called exosomes. So exosomes are essentially nano-sized, how do I explain this in simple terms? Okay, so these are essentially nano-sized, vesicles that are secreted into the tumor. They could be normal cells, they're rich in DNA, and there's a lot of applications that one can use it for. We can actually help it give us a fingerprint, if you can say, of where it's originated from. So when we have that dilemma, is this a biliary tract cancer? Is this a pancreatobiliary tract? When we have those dilemmas, there is a lot of great research going in the realms of exosomes, which can maybe help us identify and find tumor of origin. A lot of work happening there. I'm not going to be discussing it today, but that is something to look forward to. In addition to that, there is circulating tumor cell. Now, again, circulating tumor cell is very, very controversial. If I bring it up in a medical oncology meeting, I'm going to have people wondering if I've gone nuts. The reason being is it's experimental. It's really interesting. So they use the technology of flow cytometry, where they're using various IHC staining markers to see if it's ER/PR positive. There is data, and there's a lot of great studies happening there that if I can't do a biopsy, how about I take a blood sample, isolate the circulating tumor cell, isolate that breast cell, and then on that breast cell run various IHCs like ER/PR, HER2-Neu. It's work in progress. There's some great work and great data coming out from Massimo Curgiuloni, if I got his name right, or Cristofini, one of the last names. He's an Italian person. I'm forgetting his last name, but I know his first name is Massimo. And he's from the University of Chicago. And he's doing some absolutely groundbreaking work in the realms of circulating tumor cells. But the challenges that we face with circulating tumor cells, exosomes, is the technology is really difficult. So it's not as easy as just going in there, taking a blood sample, isolating that DNA, isolating that tumor cell or isolating the exosome. It's very difficult, isolating them. There are very small concentrations. So from the stability of the sample to isolation, to having a standardized assay, you're going to see in a bit that even something like circulating tumor DNA is not very easy. So it becomes quite a task putting all of this together. And while today I'm not going to be focusing too much on the role of CTCs, though I think great data is there, but the data is very shaky. One day we get great data, the next day we get data that shuts it down. Or sometimes we get data that says, hey, in this blood sample, we found circulating tumor cell, but radiologically, we find no cancer in the body. So is this a premonition that there's a relapse? Is there a premonition there's going to be a diagnosis? We really don't know what the right cutoffs are. There's been some work using cell search as a platform, but again, I think it's experimental. So for today, I'm going to stick to what is of clinical relevance, and that is with respect to ctDNA. And again, over here, you'll see that there's so many question marks. So this is just, again, a brief of what the blood component has, what is a liquid biopsy, and why liquid biopsies became very popular is with the advent of next generation sequencing, precision oncology, all of this. Something that we learned about our cancers were a lot of them are very heterogeneous. So there were a lot of studies that took the primary tumor site of a patient, did an NGS, and then compared it to the metastatic site. And again, in the metastatic site, if you took those 3-4 different quadrants in there, they saw genomic landscape was different across the board. So there was a lot of within the tumor heterogeneity, which is what we call intra-heterogeneity. And there was a lot that was happening in the difference, the discordance in the genomic landscape between the primary tumor and those metastatic sites. And that's why liquid biopsy, which essentially is the transport system of the body, became the flavor of the season and kind of became the favored sample sites. And one of the best things about it, it's non-invasive. It's a simple blood test. So it became a little bit more exciting, enticing for us in the clinic to actually consider the role of liquid biopsy and in particular, circulating tumor DNA. Now, liquid biopsies has multiple roles, and we can take it across the board, from There's great work happening in screening, and we're going to discuss this. That means a healthy asymptomatic individual, is there a way that I can actually detect that if cancer is around the corner? Is there some signature patterns that I can look for in a blood sample? So that's one thing. What if suppose the second area, what if suppose my patient has already had cancer? And I don't know if I want to escalate, de-escalate treatment. You know, the patient is at that cuff of being stage 2, stage 3, escalate, de-escalate. Patient is reluctant, but there's some poor prognostic markers. You can't get away with chemo. You know, you have these questions that come about in the clinic very often. That's another area where liquid biopsy can be helpful. In fact, there's even the role of looking based on the variant allele frequency if there's actually response to chemotherapy. So for measurement of tumor response. And last but not the least, the very classical, what we're used to doing in our clinic is instead of on tissue, can I do molecular profiling on liquid instead? And maybe pick up resistance mechanisms, pick up those crosstalks between different pathways. Can I pick up any actionable biomarkers? All of this. So across the board, we've realized that liquid biopsies have become extremely crucial and critical and of utmost importance in our clinical practice. And one of the key reasons where liquid biopsies, you know, because of the heterogeneous nature of the disease, how does it become heterogeneous? So we know it starts out with one mutation, and then along the way, as the disease metastasizes, along the way, it picks up resistant clones. So you could have one oncogenic driver, and then a couple of passenger mutations come on board, or you could have a new oncogenic driver coming in and the old one getting replaced by something new. So the biology is changing. And by the time there's progression, there's such a huge, for lack of a better word, this khichdi that has happened, where you've got multiple resistance clones, you've got oncogenic drivers, and sometimes you're so confused that who is the driver in this? Because it's just such an amalgamation of so many different mutations. And liquid biopsy was one of those that have helped us pick up the mutations that were evolving as the tumor evolved. We have seen liquid biopsy being very helpful. And why? We're going to discuss this in a bit. So let's go to the role. Let's start first with screening. I have an asymptomatic, healthy individual. What can I do here? Now, when we think of all the screening modalities that are there, right? Transvaginal ultrasound, digital rectal examination, colonoscopies, MRIs, it's very uncomfortable. So the concept came about that, okay, my patients are not comfortable doing this, but they are at high risk because of lifestyle choices, maybe because they've got obesity, they've got fatty liver, they've got hypertension, diabetes, and a host of other cardiovascular diseases. As we know, cancer is part of a far bigger complex disease pathway. So how can I pick up those cancer cases before it actually presents? So keeping this in mind, we were trying to see, what if suppose we take a blood sample, and in that blood sample, we pick up those pre-cancerous cells that will somewhat emit and give some element of ctDNA. Or there could be some methylation epigenomic changes that could be picked up, which is not the normal methylation we see in healthy asymptomatic cells. So keeping all of this in mind, there was a study that came about back in, and this is actually published in NEGM, that was called the ECLIPSE trial. Now, ECLIPSE was done with a company called Guardant Health, and this was on their LUNAR-2 platform. So what they did is they took asymptomatic, high-risk patients based on comorbidities and lifestyles who had no genetic predisposition. That means no APC, no Lynch predisposition, no genetic predisposition. And they took a group of individuals from the age group of 45 to 84. They didn't have any history of Crohn's disease, irritable bowel syndrome, none of that. So what they did is, prior to screening and doing a colonoscopy or doing anything, they took a blood sample. They said, okay, let's do screening colonoscopies and do it and put it up against this blood test. So a simple blood test, it took 2 weeks for the results to come. So what was very interesting over here, and again, take this data with a pinch of salt. This is an evolving area. But I found what was very interesting, that there was an 83% sensitivity, and they did it only for colorectal cancer, and now they're working with breast and lung and a host of others. But what really stood out for me over here was that around 83%, they did have sensitivity in detecting colorectal cancers. However, this 83% was in stage 2 and above. The stage somewhat 0 precancers and stage 1, the sensitivity was as low as 45%. And that's really low. So you rather do a colonoscopy, and there's no great benefit of actually running this test. And mind you, these are very expensive. These are 3-4 lakhs, these tests. These are not small 20,000-15,000 tests, which is also expensive. So for that cost, and especially when your goal is to pick up those precancerous where it was only 13%. And stage 1 was only 50%. Maybe it's not ready for prime time. However, having said that, I do think that it is very, very interesting that there is this sort of data that is coming out. This is evolving data. It is work in progress. Now, questions we ask ourselves is that if it does come high risk, what do I do for that patient? If it comes high risk, or it says, hey, there is cancer, how do I detect this? How do I implement it in my clinic? And let's say we do a colonoscopy as a follow-up, and the colonoscopy comes negative saying, hey, no polyp detected. Then what do you do? So there are changes, there is tweaks that are required. There's still a better understanding. But the ECLIPSE trial fared far better than GRAIL's trial, which GRAIL just failed miserably. It was picking up patients who were actually asymptomatic, healthy, did not even have the slightest precancerous, it did not even have precancerous stages, and it was still picking up random things and calling it positive, was calling it a mutation, was calling it out as being cancer stage 1. So these are evolving platforms, but I do feel maybe in a year when we come back to talk about the role of liquid biopsy, we'll have far more robust data. But yet again, I will say that this was pretty impressive, that if in stage 2 and above, you have a sensitivity of 83%, that is a good panel. I think stage 1 is the area where we are actually looking out for, where we want this being beneficial in stage 0. So some great work that's happening here. Now, let's move on to recurrence detection. And here, what you want to do is you obviously want to look at those oddball cases where should I escalate? Should I de-escalate? How do I look after my patient? Should I treat, not to treat? So we're going to discuss a little bit about minimal residual disease. Again, fabulous data, predominantly in colorectal cancer, but there's also the TRACER-X and the NTRAC trials that are coming out with respect to breast and lung, and a host of other solid tumors. But let's discuss this, and let's look at how I'm going to show you a couple of cases that I've used in the clinic for assessing the treatment response by looking at the increase or the decrease in the cfDNA or the ctDNA in the patient's blood sample. So we're going to look at that. So let's look at minimal residual disease. Now, especially I've written breast cancer here, but actually in our early cancers, be it breast, be it colorectal, a lot of times we hit this junction that you've done NACT, or sometimes you've not done NACT, you've done screening, you've done adjuvant treatment, most likely in adjuvant, sometimes it's just it's chemotherapy. Sorry, it's not adjuvant. You've done surgery, and then you don't know if you should do adjuvant chemotherapy. So when we hit these junctions, there's always that question that do you escalate or do you de-escalate? So what they did over here is that first, let's understand what's minimal residual disease. So after a patient has undergone surgery, and we have done an R0 resection, which says that there is no tumor there, it is believed that sometimes there could be some residue that could be hiding, which eventually will propagate and will promote recurrence, will promote metastasis. And this is what we call minimal residual disease, or measurable residual disease, or molecular residual disease. This phenomenon, for those who practice hematology, it's not new, it's very well established, but this is relatively new for those who are only working in solid tumors. So when we look at MRD testing, it's The logic that we're using is that if I look at various radiological screening modalities, X-ray has the ability to pick up cancer with 10 to the power 9. If I compare it to a CT scan, it's 10 to the power 7. Now, if I compare this to ctDNA, circulating tumor DNA, it's 10 to the power 5. So obviously, it's far more high sensitivity and accuracy. So what you're expecting is that post-surgery, when you take a blood sample of the patient, so 4 weeks post-surgery, 6 weeks post-surgery, you take a blood sample of that patient, because the sensitivity is higher here, radiologically, it will say, oh, no cancer detected, patient is cancer-free, it was an R0 resection. What this has the ability to do is pick up a disease, is to pick up those cancer cells even before one of the other radiological or biochemical findings pick it up. Now, there's a lot of great data in the realms of looking at in the realms of where they've done a head-on-head comparison of biochemical testing versus looking at ctDNA, these MRD assays. And what they've actually realized is that even before biochemically, that is your CA125, your CEA levels, pick it up, ctDNA was able to pick it up. Now, where the drawback comes is the site of recurrence. All sites are not the same. So if it was retroperitoneal disease, it was quicker to have sensitivity with respect to the biochemical test, was far more sensitive versus ctDNA testing. And the reason being is retroperitoneal disease is a poor shedder. So till from the tumor site, if the circulating tumor DNA does not get released into the bloodstream, how are you going to pick it up? So that's one of the key areas where I wouldn't be a complete 100% convert and say, hey, let's forget doing biochemical testing and let's do, MRD testing every time, because I do know the site varies. And there's a very beautiful bar graph, and I kind of forgot adding it here, but there's a beautiful bar graph that is actually showing the correlation of the site of DNA, of the site of recurrence, and its correlation with ctDNA. So again, it's very sensitive, but at some tumor sites, maybe not the most sensitive. So how do we test this? There are two ways of testing for MRD. One is a tumor agnostic approach, and one is a tumor-informed, a bespoke approach. So what does tumor-informed mean? Tumor-informed means that you take the tissue of the surgical specimen and you send it for NGS. And if you look at those very typical colorectal cancer cases, colorectal cancer mutations that we tend to see, the usual biomarkers are usual suspects. In addition, you also send a blood sample. And then you do serial testing with blood samples, and it will compare it to the baseline mutational study. So if you at baseline have done 12 genes or 50 genes, depending on what the panel is, it will every time on liquid biopsy go back and look at those 12, 50 genes. Vis-a-vis plasma only is that, all right, after 4 weeks or after 6 weeks or 8 weeks post-surgery, we take a blood sample and we look at all the genes. We go beyond the classical colorectal. And what they started to do is they started to look at the methylation signatures. So for those of you who practice in GI oncology, you would know that colorectal cancers, those methylation signatures are so very important. Think about your MSI testing, right? We do know that colorectal cancers and all we see a lot of methylation in there. Sorry, not MSI, apologies. But what I'm talking about is the methylation changes that we tend to see. It's very high in colorectal cancers, not MSI. I made a mistake there, sorry. Those methylation changes that we tend to see is very high in colorectal cancers. Around 20 to 25% of colorectal cancers will have some element of methylation changes. So when I factor that element into my NGS, every time I'm going to be doing a blood test, my sensitivity of picking up a recurrence is much higher versus just going back and looking at those classic baseline genes that I've looked at. Another very important thing to remember is cancer, when it has a recurrence, it doesn't always have the same genomic landscape it had at baseline. It evolves, it's heterogeneous. We know when, in colorectals, you could be KRAS mutant at baseline and you lose the KRAS status, or it can be KRAS wild type at baseline. And on recurrence, it can be KRAS mutant. That's why we go on regularly checking for the RAS-RAF mutations. So the issue here is that while tumor-informed, because it's a smaller panel, because the assays are maybe a little bit more robust. It does sometimes become a little bit more favored platform. But in all honesty, what I do feel is that when we're looking at these MRD signatures, maybe an agnostic approach is better, because we have learned our diseases are heterogeneous. So getting a new view every time we take a blood sample might be more beneficial. But yes, the sensitivity of the test should not be hampered. And obviously, there has to be data backing all of this. Now, one of the biggest drawbacks of doing this testing is the cost. It's not as easy as it seems very easy doing the testing. You give a tissue, you give a blood sample, and you get it across and you get the test done. These are expensive. And the question now is, if I do serial testing, do I do it every 4 months? And if I do it every 4 months, for how long? So there are a lot of clinical trials. I'm just going to show you over here. So we have a lot of clinical trials that are across the board, and all these clinical trials are still work in progress. So I don't have an OS, I don't have a PFS. All I know is the most recent trial, which has the longest data where they monitored patients, is maybe the Pegasus trial, which they've been doing for the last 5 years. And again, that's in colorectal cancers, where they have seen the benefit of doing MRD testing. And those patients at baseline that tested to be MRD negative, which means at baseline post-surgery, when we did testing, those who were MRD negative continued being MRD negative even after 5 years. And those that were MRD positive, which means there was ctDNA, those eventually did have a relapse in the first 5 years. And then there were some cases where it was MRD positive and there was a seroconversion, which means it went from being positive to negative after escalating treatments. So some of the key concerns that come about in the clinic is that how much can we trust this in actually going ahead and de-escalating? So I think escalating, everybody's very comfortable. But in those poor prognostic cases where we have poor pathology, MMR, proficient, where we've had some perforations and a host of other poor prognostic markers, a lot of times, I don't think a lot of us are yet convinced by the data if we should de-escalate. So again, it is work in progress. And even with the addition of epigenetics and this methylation signatures, I still feel that it's still work in progress. So there is some great data coming out. I think somewhere with escalation, we're all very comfortable to a certain extent, but de-escalation maybe not so. And the data is, again, I think there's more data in GI versus the other tumors. So I'm going to just show you a couple of cases from my clinic. So this was a young 56-year-old female, triple-negative breast cancer. She was stage 2B. She underwent neoadjuvant chemotherapy, and then she underwent surgery. And at baseline, post-surgery, she was very anti-chemo, did not want to come back. And we said, okay, let's do ctDNA testing. Let's see what's happening. So we did the Garden Reveal test, which is what this MRD testing is. And it came back positive, which meant that we were not very comfortable leaving it as is. So the medical oncologist at that point did combination of nab-paclitaxel and radiation. And I think this was done more psychologically to help the patient and convince the patient to go ahead and do chemotherapy and kind of finish the whole adjuvant treatment. And we did that. And then we went ahead and we did a Garden Reveal later in like around 4 or 5 months. And then she came back negative. And then we again did it in November and she's negative. And I just got her report, so I didn't have time to change this, and she continues being negative. So we're doing serial testing to monitor and see if we should escalate or de-escalate, and she was refusing any form of treatment. So we did find this treatment modality, this observation modality to be beneficial for especially those patients who are not the most compliant. Now, here's another patient, a triple-negative breast cancer, 45-year-old female. She was stage 3. She was on chemotherapy. And what we did is from baseline. So we use ctDNA and this whole MRD testing to a certain extent to look at the change in the ctDNA levels. If the ctDNA levels went down, that means the patient was responding. And we actually increased and increased the treatment or reduced the treatment based on these results. And here decrease. So we finished the chemotherapy, switched her to the MRD testing, and she continues to be negative. There's actually a very nice study that if those who are interested, they can read about, is the Victory trials, where they've actually looked at the levels of HER2 amplifications, and they've increased and decreased the dose of lapatinib based on the ctDNA. So there's a lot of great work happening in this area, so I'm very optimistic about it. So here's another patient, 65-year-old female, CA breast. She had an Oncotype DX score of 35, so we had to give her chemotherapy. And if you look at these trends, right? So when we started off, she did have, she was ctDNA positive, so she was given chemotherapy. And then we regularly monitored this. She was part of the clinical trial when we started ctDNA and MRD testing. And if you look at it across the board, post-chemotherapy, how the trends have come down, and she continues to stay negative. I have lost her to follow-up, but at least till 2023, I do know she was ctDNA negative, and the trial got over after that. So I don't know what's happened, but I can tell you for at least a year and a half, she was ctDNA negative using the MRD test. And this is another very interesting case of a 31-year-old male. He is CA colon stage 2 adenocarcinoma, moderately to poorly differentiated. He had a PMS2 loss, no germline mutation, had it checked for. His family history was positive. There was synovial sarcoma, there was colorectal cancer, germline was negative, and he had surgery and he was put on regular follow-up. He did not want chemotherapy. He did not want anything. He was newly married, so he honestly did not want to go through the whole chemo and radiation and, you know, just the usual. So we put him on ctDNA testing, we put him on MRD. And here, if you see, he's been doing it every 4 months. This was the first test back in February, which was around 7 weeks post his surgery. Then this was a second test, he was negative, third test, fourth test, so he continues to be negative. And for his sake, I really hope he continues being negative. So yeah, I think MRD testing in our clinical practice, I do feel it's a very, very important tool in our armamentarium that is coming about. So it is a little bit early, but I do feel that with GI cancers, especially your colorectals, where you're in the conundrum, should I not? There is pretty good data from ACT3. ACT3 is work in progress, where they're looking at biomarkers like your MMR, BRAF, KRAS. They're actually implementing and, you know, taking into account those statuses too. But even based on Pegasus trial, which is Dr. Aparna Parikh's paper, I think it's a fantastic read for those who are interested. It just shows how beneficial MRD testing, and especially when you have the epigenomic signatures, and how there's a more than a 5 to 7% extra pickup rate of ctDNA positive. So that epigenetics makes a huge difference. And I come to now the more frequently used, if I could say, the ones that we're more comfortable with, which is in our advanced and metastatic disease. So we do know, and I spoke about this earlier, that there are different evolution patterns that the tumor undergoes. So we have the linear one where the original, you know, like your lung cancer, it could be L858R, EGFR, and then is replaced by a new clone, which is EGFR T790M, and that can be C797S, and then suddenly there's a new driver, there's a MET exon 14 skipping. So it goes through a series of changes. That's your linear clonal evolution. And then you have your branched, where there are multiple clones coming together and there's absolute confusion as to what's happening within the tumor. You tend to see these more with your head and neck cancers. But what's important is that all these resistance developments, time and again, and these resistance mutations, they are small in size. They're those really, really low VAFs, but they're really one that go and disrupt your entire treatment. So liquid biopsies are known to being, especially ctDNA in your metastatic disease, are known for being extremely beneficial. And that's why it becomes sometimes the preferred platform. Now, this is again just showing you as to how these tumors evolve, right from the formation to when they get released into the system from the primary tumor. And I realize primary spelling is wrong there, but from the primary tumor, they get released into the system, and there's a host of changes that tend to happen. And if you look at this, right? Primary tumor, early stage untreated. You can look at it that in early stage, the ctDNA is in low abundance. Vis-a-vis advanced or after treatment where it's more ctDNA, where we could have higher tumor DNA. So the key, if I could say one of the key takeaways when we talk about ctDNA for molecular profiling, for resistance mechanism management, for assessing tumor heterogeneity, it can only be done in a metastatic stage. Only for lung cancer can you do it for stage 3B and above, but for all the other cancers, it has to be above stage 4, so that means it has to be metastatic disease for the cancer to shed in the blood and for us to isolate it. And that's why ctDNA is not advised in early stage cancers. And I go back to what I said earlier, that different sites are for shedders. Everybody is not the same. So if my disease is confined to the brain and technically it is metastatic, it's going to be very difficult isolating that ctDNA because of the blood-brain barrier. It's very, very difficult. And there's some great studies where they're using cerebrospinal fluid, where they can actually look at those, especially in your leptomeningeal diseases, where you can actually look at CSF and isolate the DNA from CSF, but that's work in progress. The sample stability, temperature, there are a lot of issues that go about in the lab work. So I would be very cautious with CSF as a sample. RGCI has done some great work around it, but yes, there were certain issues with respect to wet and dry lab, and more to do with wet lab than dry lab. So rule of thumb, whenever you're going to do molecular profiling for liquid biopsies, you have to ensure that it is metastatic disease and it's not confined to the brain, or it's not confined just to the retroperitoneal, because these can be low shedders. So there are different requirements that we look at, and I've called it an ideal liquid biopsy panel. And the reason is because of the depth of coverage. Now, depth of coverage, I know Dr. Arun would have covered this yesterday, but just to go over this is depth of coverage is essentially looking at the number of times you read a particular segment, a particular fragment of the DNA. Now, the more you read it, the more you increase the depth of coverage. You read something 15,000x, 20,000x, 30,000x. Your sensitivity of reporting those mutations increases. So something at 15,000x minimum, you can report a mutation as low as 0.01%. So the VAF can be as low as 0.01%. And we have learned with a lot of these resistance mechanisms, like your RB1s, like your TP53s in some cases, like your, I suddenly blanked out, but there are a host of these resistance mechanisms that will be available at really, really low VAFs. And for a liquid biopsy panel, a ctDNA to have concordance with tissue biopsies, the normal classical, tissue testing that we do, having a minimum depth of coverage as 15,000x is mandatory. You can then trust it. If it's more than that, if it's less than 15,000x, I'd be very dicey about that report. I'd be very, very careful before I act on anything, even if it's actionable. So there are some new features that are coming into liquid biopsy. I spoke about methylation signatures earlier, and we're actually now using methylation signatures even in our normal ctDNA testing. And slowly these signatures are being brought into mainstream, into clinical practice, because we have learned various tumors, like around 24% of TNBCs, around 25-27% of colorectal cancers have methylation. And with normal genomic studies, we tend to miss out these methylation signatures that are so important. If you think of a BRCA1, you think about the RAD51C, methylation in these, the BRCA1 promoter methylation, the RAD51C methylation, all of these, if positive, show a sensitivity to PARP inhibitors, which means it opens avenues for treatment. And similarly, we are starting to see that sometimes methylation can be known resistance mechanisms in other cancers. So knowing this part becomes extremely important today when we are treating our patients, because you need a 360 view of the tumor and not just the classical, just the classical molecular profiling. So when I spoke about concordance, I said that for ctDNA testing to be at par with tissue, there has to be liquid biopsy. So the liquid biopsy's depth of coverage has to be minimum 15,000x. And all these clinical trials that are there, it could be with lung, it could be with breast cancers, what they've all alluded to is that liquid is not inferior to tissue. In fact, what tissue has missed out, like resistance mechanisms, liquid has picked it up. So there's great data that's saying that you can trust liquid biopsies. There's great data showing that they've used it across various tumor types. I've just focused on these because these are some of the initial ones. But there are a plethora of various trials that have come out showing how robust and how liquid is not inferior to tissue. So keeping all of this in mind, I thought, let me just walk you through the different cancers. The poster child for molecular oncology, molecular biology, precision oncology, you name it, is lung cancer. 50% of our lung cancer patients are going to have an oncogenic driver, which means I just have to give them one tablet. It's as simple as that, treating with a tablet. However, identifying it, we use tissue biopsies and we use liquid biopsies. And look at this, there's a plethora of treatment options that are available. And the beauty is that we use liquid biopsies over here to actually pick up, especially on progression or even at diagnosis, a treatment naive. If I can incorporate liquid biopsy, sometimes tissue misses out on those lurking resistance markers that are already there. So sometimes having that upfront can be really, really beneficial when we're treating our patients with lung cancer. And keeping this in mind, there is the IASCLC group, which is an International Lung Cancer Group, Society of Lung Cancer, and Dr. Christian Rolfo. So this is back in 21-22, where they came up with a consensus that said that, okay, in the case of liquid biopsies, in the case of these lung cancers, in an ideal world, try and do tissue and liquid together. And what tissue will miss out, liquid will pick up. What liquid will miss out, tissue will pick up. So in an ideal world, it should be together, complementary. But if tissue is not able to pick up a mutation, they very strongly recommend to do liquid. And if tissue is an issue, they very strongly recommend to do liquid. And the same is echoed in our NCCN guidelines. Similarly, we see these in colorectal cancers, and we use this a lot for actually monitoring the RAS, the RAS pathway. So we're looking at KRAS status. We know there's this whole phenomenon of neo-RAS where the state of RAS goes from being wild type to mutant, mutant to wild type. So again, using ctDNA can be very, very beneficial, and especially for those resistance mechanisms. So if you're treating your patient on anti-HER2 therapy, for example, if you have a PIK3CA lurking around, we know PIK3CA is a resistance mechanism to HER2. So just something to be on the lookout for, that sometimes when you have a 360 view of the tumor, it helps you make better decisions with respect to your treatment. And look at this, we even use this in triple-negative breast cancers. There's a plethora of biomarkers that we can be looking at. You've got the DNA damage repair pathway. Obviously, we've got immunotherapy. We've got the PI3K, AKT-P10 alterations. All of them have some element of treatment modalities that are available. We've got drugs for them. And obviously, we've got our very classical agnostic markers. Similarly, for our HR-positive tumors, in fact, in the hormone-positive tumors, the pickup rate of PIK3CA is higher, and that's what the SOLAR-1 trials also showed, was higher with ctDNA versus tissue testing. So those resistance mechanisms, especially when your patient's on a CDK4/6, you could have an RB1 lurking behind. Or if your patient is on aromatase inhibitors, ESR1 is another very common resistance mechanism. So all of these get picked up, and there's a lovely case study that was presented way back in 2018 by Dr. Chandrulapati at ASCO. And he did tissue and liquid. So imagine this is way back in 2018, where liquid was really not the mainstay or a flavor of the season. And what he saw was that in a case of breast cancer, he started treating the patient with chemotherapy, aromatase inhibitors. And at baseline, when they did tissue testing, ESR1 was negative, 0. So in January of 2016, he tested for ESR1, the tissue was negative. In February, and then in June, he picked up an ESR1 mutation on the tissue, and that was also after there was progression. Then liquid biopsy was also done. In those days, it wasn't NGS, it was using digital droplet PCR. And what he saw was that at baseline in January, February itself, ESR1 had already presented. It was sitting at 0.01. And by the time in June, they did a head-on-head comparison where tissue said, oh yeah, we have ESR1, it's around 0.02. The liquid biopsy had already picked it up at around 0.6 or something, which is much higher. So liquid biopsy proved to be far more sensitive in picking up those resistance mechanisms versus, and the resistance mechanisms are the one that actually disrupt your treatment. So that's why I go on harping on resistance mechanism more than actionable biomarkers. We know we pick an actionable biomarker, but it's the resistance ones that can really do you a number in your clinic. And similarly with biliary tract cancers. Now, I think biliary tract is going to be the new poster child for this precision oncology like lung cancer. It's molecularly very diverse. And honestly, it depends on the location. Is it intra-hepatic, gallbladder? They all have their unique molecular profile. And I think that is absolutely, absolutely brilliant with the way how diverse this cancer is and how heterogeneous it is, but it also opens up avenues for a lot of treatment options. Now, keeping in mind with liquid biopsies, and while I'm harping about how great it is, it has another beautiful benefit which tissue cannot do, and that is pick up something called a BRCA reversion. So in your BRCA mutant breast, ovarian, pancreatic, prostate cancers, post multiple lines of treatment of platinum chemotherapies, PARP inhibitors, somewhere the BRCA kind of repairs itself, not completely, maybe partially, and goes from being mutant to wild type. And this is more common in your BRCA2s versus BRCA1s. So what you'll start seeing is sensitivity getting lost. So it becomes insensitive, it becomes resistant to platinum chemotherapy, it becomes resistant to PARP inhibitors. So suddenly your germline positive patient, with BRCA or even somatic, somewhere it suddenly becomes resistant and you can't understand why nothing's working. There is a high possibility there is a BRCA reversion. And what you'll see on the report, and I'm going to show you a case, are multiple mutations that are linked up next to one another, and it's able to repair itself. And that can only be done on liquid. It cannot be picked up on tissue. So another area where liquid biopsy is really good. So if liquid is so good, does it mean it can be better than tissue? Can I replace tissue and say, I don't need to do tissue. Why should I go do biopsies apart from an IHC to confirm the diagnosis? Let's just do liquid biopsies. Unfortunately, we're not there yet. There are limitations. As I said, not all tumor and tumor sites are great shedders. So even if it's metastatic, sometimes we do tend to find errors where liquid biopsy has not picked up a mutation and tissue has picked up that particular mutation. And because of that, it sometimes can miss out on certain subclones that are at a lower frequency, which in turn kind of doesn't address the issue of tumor heterogeneity, which is my main reason for doing ctDNA testing. Now, technical challenges. If I'm saying a depth of coverage has to be 15,000x, it's very expensive. And if you don't have the right bioinformatics pipeline, if you don't have ultra deep sequencing, there is a huge, huge possibility of having errors and having a lot of noise in that NGS. And if you're not able to distinguish between that, and if you don't have a good bioinformatics pipeline or bioinformatician, if you've not isolated the ctDNA from ground zero properly, you're going to have a lot of errors. It's not as simple as doing DNA extraction from tumors. It's a far more complex wet lab, and a lot of our people do not have the ability and the competency. A lot of our domestic partners are not at par with what the international guidelines, the AMP-CAP guidelines state. So one is obviously maintaining depth of coverage. And more importantly, before we launch it into clinical practice, it should be validated. At least 100, 150 tissue versus liquid has to be done before we bring it into clinical practice. And unfortunately, that does not happen. They're barely 5'10". They use these horizon controls, or they send it abroad under the pretext of ILC interlab checks. And unfortunately, it gets launched into clinical practice as low as that. So whenever you're ordering a liquid biopsy, ask for validation data. If that lab has not published the liquid biopsies, run in the opposite direction. If they've published it, see on how many genes, how many samples, and where was the testing done? Who have they compared their samples with? What is the overall assay becomes extremely, extremely important. So I would be looking at all of this before I go ahead and treat. Now, another area where ctDNA becomes a challenge, and that is when we look at these genomic signatures. HRD, I do know there's a liquid biopsy company in the US that is coming out with the signature, but it's not very easy. This is fragmented DNA, and it's very difficult to deal with fragmented ctDNA for these various calculations. There's no proper standardized algorithm, so area of concern. Similarly, with tumor mutation burden, we need a large exonic coverage, and it may not be that easy doing it on liquid biopsies, especially at the depth of coverages that we're looking for. And if it's a low ctDNA shedders, it becomes an even more bigger challenge to pick up these cases. And then you have the additional problem of CHIP mutations. CHIP mutations are essentially clonal hematopoiesis of indeterminate function. These are, the PIK3CAs, EGFRs, TP53s. You see, these are these very, very low percentages that sometimes, they could be from discarded cells for old smokers, old age individuals. A lot of these get misread as being the driver mutation. So you have to have a good CHIP filtration system that you're not overcalling mutations that are actually not mutations and are just of indeterminate functions. So another huge challenge with liquid biopsy, especially if you don't have the right people and the right assays. So very quickly, what do I do in my clinic? If my patient is metastatic, or if it's lung cancer stage 3B and above, I ask the question, is profiling required? If profiling is not required, I don't do it. It's not for everybody. And if it's required, do I want to do tissue first? Yeah, in some cases, I would do tissue first. Like ovarian, I prefer tissue. I want to do HRD signature. I want to look at loss of heterozygosity. So I would do tissue first. But if tissue is an issue, I would do liquid. Now, when I'm doing liquid, these are a couple of things that we have to keep in mind. Depth of coverage, stage of disease, where is the metastatic site? If it's confined to the brain, no point doing liquid biopsy, just forget about it. Assay validation. And between the last chemotherapy or whenever they do a PET scan, there has to be a minimum 14-day washout period. Ideally, we should do DNA and RNA, especially for fusions, but I know doing RNA on liquid is very difficult, and that's where validation becomes important, where you ask them to show you on DNA NGS, on liquid, what has been the validation with fusions. There has to be a head-on-head comparison and not just say, oh, we did 20 samples, 15 samples. No, ask for fusion data. How have they validated it? And obviously the different signatures like TMB and all, what is important? If I need HRD, I know liquid is not my go-to. I will need tumor testing eventually. So it becomes extremely important. Now, if I wait for the disease to progress, and if tissue is sufficient and I do tissue, but I don't find an actionable biomarker, I may consider doing liquid biopsy. And if not, tissue is not available, I'll do liquid biopsy. So I do think liquid is good, but it again boils down to what your tumor type is. And very quickly to walk you through cases, this is a young 46-year-old female. She was CA breast, metastatic disease, ER/PR positive, HER2-negative. She was started on a CDK4/6 inhibitor. She had a relapse after 3 years. When she had a relapse, because it was predominantly bone disease, bone lesions, so we could not do a rebiopsy. We sent it for ctDNA testing, and we picked up a very classical ESR1 mutation and a PIK3CA. She was started on PIK3CA and did relatively well for quite some time. Here's another case of a 36-year-old female. She was ER/PR positive, HER2-negative. She had a genomic, she had a germline BRCA2 mutation. So she went through the regular treatment, eventually put her on olaparib and tamoxifen. But after 3 months, she came back complaining of axillary swelling. We did a rebiopsy from there. It was metastatic disease, which was really weird that within 3 months, she had a recurrence and she didn't respond to olaparib, even though she had germline BRCA2. So we did tissue testing, and this further drives the point of what I said earlier, that it is important. Tissue did not pick up what we call here the BRCA reversion. So this is exactly what I was telling you about. tissue cannot pick it up, and liquid becomes so important. And this explains why she was not responding to platinum, why she wasn't responding to PARP inhibitors. She started on carboplatin. Again, over here at baseline, this patient was EGFR mutant positive, was started on afatinib, eventually progressed. Then we did a rebiopsy on tissue, came back negative. So we did a liquid biopsy, 79, 80-plus-year-old individual. And liquid was able to pick up MET exon 14 skipping. Because the VAF was 0.4%, my tissue missed it out. 81-year-old female. At baseline, tissue was insufficient, so we did liquid biopsy. I remember this was during the peak of COVID, the second wave, and she had a CD74 ROS1 fusion. She was started on crizotinib, then she had resistance, refused to do tissue, and rightly so, so we did liquid. Over here, we found a ROS1 G2101A mutation, a point mutation. So on this, we started her on lorlatinib. Unfortunately, it was short-lived. She acquired another resistance mutation, the G232R, and we started her on chemotherapy. And unfortunately, we eventually lost her. But what was interesting over here is this whole thing was done on liquid biopsies, and we were able to pick up mutations. Another very important point is the G2101A is a known resistance mechanism to your crizotinib. So liquid biopsy was able to pick these up. And this is a case of, and I love this case, this was a case of a metastatic lower GE cancer, went through a plethora of testing. And you can see we kept on doing liquid biopsies to pick up actionable markers. And this was possibly the first time it went from being MSI stable to MSI high. And I've never seen this. In the last 20 years of doing this, I've not seen an MSI status change. And I remember when this came MSI high, and we were like, should we give immuno? Should we not give immuno? So we went back to the laboratory, had it rechecked. We somewhere coaxed the person into giving us, allowing us to do a tissue biopsy. We confirmed it was MSI high, and he responded beautifully, is an understatement, to immunotherapy. And my last case, and this was such an important learning for all of us, 37-year-old male, non-smoker, had lung cancer. We sent it for testing in India to a domestic partner, where we now learned that the the depth of coverage was so poor of the tissue and the liquid that even though no mutation was detected, we should have been much, much more careful when in a non-smoker, 37-year-old, no mutation was detected. We started this patient on immunotherapy. It was so short-lived, he barely responded. Then somewhere we were able to convince the patient, let's send it abroad. And when we sent it abroad, we found a BRAF V600E mutation. And it was so unfortunate that, yes, there were other resistance mutations and all of that lurking around, but this was missed out. And then when we went back and we retested the original samples that we had, and we realized that this was actually missed out because of the lacunae in the assay. The assay was poorly validated, and it was just a very unfortunate case. So I think my key takeaway with liquid biopsies is it is a brilliant platform that's here to stay. I do think the data is much stronger in the advanced metastatic setting, where we have to make treatment decisions with respect to the tumor biology. MRD is exciting data, work in progress. We're not there yet, but maybe in colorectal we can implement it when we're in a little bit of a confusion. And screening, I think there's a lot of great work happening, but we need more work before it's ready for prime time. So on that note, I'm going to stop presenting, and thank you so much for hearing me waffle through for the last 45 minutes or so. And I'd like to open this, and I'm very happy to take any questions. Thank you so much.
Well, thank you. Thank you very much for that wonderful exhaustive overview as well. I think all the residents would have definitely immensely benefited from your overview. So just to set the ball rolling, probably you can tell us about DNA fragmentomics as well, and DELPI index, and how effective or how useful that it would be. And also you can probably tell us about tumor-informed versus tumor-agnostic ctDNA testing as well while you're at it.
Sure. So I think tumor-informed, as I spoke about a little bit earlier, is that we are looking at tissue. In the informed, we are looking at mutations, at biomarkers that are associated with that cancer type. So at baseline, we make a decision that if this is a if this is a colorectal cancer patient, this is the mutation that is, these are the mutations that were there at baseline in the tumor, in the surgical specimen. We do a liquid biopsy, a blood sample, and we do a comparison. And then we do serial blood tests over 3 months, 4 months, every 3 months, every 4 months. Now, the negative in all of that is, that when the disease does have a relapse, and if it has a relapse, if the biology signature has changed, it won't be picked up in tumor informed. In tumor agnostic, they're using a blood sample. Ideally, you want to do it pre-surgery and then post-surgery, but a lot of studies are doing it post-surgery after 4 weeks, 6 weeks, 8 weeks post-surgery, and they look at all the mutational markers and the epigenomic signatures. If those epigenomic signatures or the tumor markers have any mutation in that, then it comes as ctDNA positive. So it's reevaluating everything every time you do sequential testing. And that's why somewhere agnostic theoretically seems to be better than informed. Is there a head-on-head comparison between the two? Not yet. But I do know there's some people working on a head-on-head comparison between this and that. So, yeah, it will be interesting to see how this goes on. With respect to LP and fragmentomics, to be very honest, I'm not very sure, and I don't want to sound intelligent and just make a mess of it. I do know fragmentomics, there is some great studies coming about, but I'm not very well versed with it, so I'm going to refrain from commenting there, sorry.
No, thank you very much once again for illustrating the difference between tumor agnostic versus informed. And like you rightly said, for us as clinicians as well, when we talk about re-challenging a particular drug, like the KRAS, an example like you just picked up, KRAS, they can lose KRAS expression as we go along because of clonal evolution or selection pressure hypothesis as well. So that gives us a chance to re-challenge or re-expose the patient once they become again wild type to KRAS, to again EGFR inhibitors. So thank you very much for highlighting those aspects once again. We'll probably open it up in the discussions as well to see, and we can take any questions if there are any.
Sure.
Thank you, Dr. Aparna, for the wonderful presentation. We all enjoyed your talk. Thank you very much. I think we are running out of time for the next session. And thank you, Dr. Kripashankar, for moderating.
Pleasure.
All right. Thank you so much, everybody. And thank you so much for having me. Thank you.